educator, researcher, and clinician. He has over 200 publications and has served as a member and advisor to organizations such as the National Osteoporosis Foundation, the International Osteoporosis Foundation, and the World Health Organization, where he served as an advisor for the development of the FRAX tool. We are really fortunate to have Dr. McClung among us today to teach us about osteoporosis. Thank you for making the time, Mike.
Liz, thank you for that, and good morning. It's a great pleasure to be back at the Grand Rounds and to see familiar faces from years past. The opportunity to think about osteoporosis is timely for a variety of reasons, and we chose to talk about the most vexing clinical question, or the most common question that I'm asked as I travel around the country about managing osteoporosis, and that is how to deal with patients on long-term therapy, or how to develop a strategy for the long-term management of patients with osteoporosis. I serve as a consultant for some of the drug companies that have drugs that we'll talk about today, and so that's the disclosure part. We've talked before over the last 25 years here about osteoporosis, and during that time we have come an amazingly long way in our understanding not only about the pathogenesis of this disorder, but about the whole clinical picture. We've developed diagnostic criteria, diagnostic tools, treatment guidelines, and very effective therapies. We recognize that osteoporosis is a systemic condition characterized by low bone mass and architectural deterioration that results in weakness and fragility of the skeleton, resulting in an increase in risk of serious fractures like spine and hip fracture. Like many other chronic diseases that we deal with, osteoporosis is a disorder that requires long-term therapy, and that will continue to be true until or unless we develop a cure for this problem. Since 1995, we've developed a whole variety of drugs with different mechanisms of action that in very well-designed clinical trials have been documented to substantially and quickly reduce the risk of important fractures. But unlike therapy for other conditions, there is a perception that osteoporosis therapies can or even should be stopped after an interval of time. And that perception comes from several sources. First of all, bisphosphonates, the most commonly used treatments for osteoporosis, have a very unique pharmacology by being deposited in the skeleton and having a very long skeletal half-life. That leads to the perception that therapy can be given for a short time, stopped, and that the therapy continues to work for a long time because of the very long residual deposition of the drug in the skeleton. Secondly, like almost every other drug, we don't have actual clinical evidence and clinical trials documenting either the efficacy or the safety of the drugs beyond the pivotal fracture trials that have lasted, for a variety of reasons, for only 3 to 5 years. That's not unique to osteoporosis. Hypertension studies, cardiovascular protection studies, diabetes studies rarely go for more than 5 years, yet we don't consider stopping therapy in those disorders. And the other possible consideration is that there is increasing concern, or has been increased concern, about very rare side effects that appear to increase in frequency with increasing duration of therapy, and the misunderstanding of the relationship between the long-term benefits versus the very rare risk associated with long-term therapy have contributed to a decrease in the utilization of bisphosphonate therapies. Between 2008 and 2012, there was a 40% decline in the number of osteoporosis prescriptions written in the United States. Part of that is probably appropriate. In 2008, new guidelines were introduced by the National Osteoporosis Foundation, focusing treatment on patients at high risk for fracture. And there were patients in the late 90s and early 2000s who were begun on therapy for the prevention of osteoporosis, patients at low risk of fracture who, in hindsight, were not appropriate candidates for therapy. But the marked decrease in numbers of prescriptions for osteoporosis goes against the fact that during that interval of time, the number of patients or individuals in our country over the age of 65, of course, is gradually and progressively increasing. More importantly, there is no disagreement that patients who have experienced a fragility fracture of the hip have osteoporosis, and we have very strong clinical data that treating those patients with an osteoporosis drugs effectively protects them from subsequent fracture and, importantly, reduces mortality by about 25 to 30% over an interval of 2 to 3 years. Yet, despite that knowledge, and despite virtually no discordance in thinking that patients with a recent hip fracture would be candidates for therapy, there was a decrease in the proportion of patients with recent hip fractures receiving osteoporosis medicines from 15% in 2004, a very abysmal number to start with, down to an even more pathetic 3% during the last quarter of 2013. That's what happened in the United States. In contrast, in the UK, the proportion of patients treated after a hip fracture increased dramatically over that same interval of time, from 7% in the year 2000, before we had evidence that treatment after a hip fracture reduced the likelihood of subsequent fracture, up to 46% in 2010. Interestingly, this marked increase in the likelihood of treatment after hip fracture coincided with the initiation of what were called fracture liaison services, nurse-led clinics that focused on secondary prevention of osteoporosis with the identification of patients with recent fragility fracture, evaluation, and then initiation of therapy according to current country guidelines. Other evidence that the treatment of osteoporosis is actually declining despite increasing knowledge about effectiveness of therapy is that rates of bone density testing for women over the age of 65, women who we believe are appropriately tested, decreased by 40% between 2008 and 2014. And for those few patients who began therapy, the persistence or the likelihood of patients remaining on therapy for more than a year is less than 50%. Again, not unique to osteoporosis, but another factor in the set of factors that lead to what we believe is a very real treatment gap in the United States. A very small proportion of patients who are appropriate candidates for therapy are actually receiving therapy. Colleagues just earlier this year described this series of events in an editorial in our Bone Journal titled "A Crisis in the Treatment of Osteoporosis," outlining the fact that we are not taking full advantage of all the information that we have gleaned and developed over the last 20 years. So the objectives of the next 40 minutes will be to review with you the benefits and the risks of long-term osteoporosis therapy, to talk about the effects of discontinuing both bisphosphonates and non-bisphosphonate drugs, and then to present a strategy for the long-term management of patients with osteoporosis. We're aware that the bone loss that happens after menopause in women and with aging in both men and women is a consequence of an imbalance in the process of bone remodeling. Bone remodeling is a very sophisticated, dynamic process by which old skeletal tissue is gradually removed. Specifically, parts of the skeleton where microscopic damage has occurred are resorbed by osteoclast, and then that old bone, or the place where the old bone was, is filled in by osteoblasts. That process of bone resorption followed by bone resorption and formation is very tightly coupled by fascinating hormonal and regulatory processes. The drugs that we have to treat osteoporosis are mainly designed to alter or to modify the bone remodeling cycle. Almost all of the drugs that we use to treat osteoporosis, particularly bisphosphonates and denosumab, the rank ligand inhibitor, work by decreasing rates of both resorption and formation. In doing so, the balance or the imbalance that occurs in older individuals is minimized, rates of bone loss are slowed or stopped, the bone is strengthened, and fracture risk is reduced. We have one drug that stimulates bone formation, the bioactive form of parathyroid hormone. When given intermittently, PTH stimulates bone formation. It also stimulates bone resorption, but at least during the first year or two of therapy, there's a net gain in bone and a restitution of some of the structural abnormalities that characterize osteoporosis. I'm going to focus on the long-term management of patients receiving either bisphosphonates, by far the most commonly used drug, or denosumab. I'll not talk about teriparatide. Its use is restricted generally to an interval of 18 to 24 months, and so long-term therapy really isn't a part of our discussion about its use. The therapies that we use for osteoporosis are given predominantly to improve bone strength and to reduce the risk of fracture. And I would contend by showing you a modest amount of data that the drugs we have are very effective in doing that. In placebo-controlled trials in patients with osteoporosis, bisphosphonates and denosumab reduce the likelihood of experiencing a new vertebral fracture by 60 to 70%. The likelihood of experiencing multiple vertebral fractures is reduced by 75 to 95%, almost a miraculous effect. Hip fracture risk is reduced by some 40 to 50% with therapy, and the effect on reducing the likelihood of other non-spine, non-hip fracture is more modest. So wrist fracture, ankle fracture, shoulder fracture risk is reduced by somewhere between 20 and 30%. In general, the drugs are quite well tolerated compared to other drugs that we use, and in the clinical trial setting, the drugs have been extraordinarily safe. I give you these two examples from the last two large pivotal trials with osteoporosis drugs. The Horizon study looked at the effect of annual infusions of intravenous zoledronic acid. The Freedom study looked at every 6-month subcutaneous administration of denosumab. Both studies enrolled almost 8,000 patients, followed them for 3 years, and in both studies, a 70% reduction in vertebral fracture risk was observed, 40% reduction in hip fracture risk, and a 20 to 25% reduction in non-spine fracture. The results that you read about in the journals with regard to these drugs always looks at fracture rates after 3 years. That's because the FDA requires 3-year studies with fracture endpoints for registration purposes. But it's important to appreciate that the drugs have the onset of therapeutic effect much more quickly than that, and that within months of beginning therapy, the full effect of fracture risk reduction is observed. In the alendronate studies, the cumulative incidence of painful or symptomatic spine fracture and of hip fracture are shown here, and within months of beginning therapy, certainly by a year, there is a significant reduction in the likelihood of these two fractures. In both the Horizon and in the Freedom trial, x-rays of the spine were taken initially at 1 year and then annually thereafter. The full effect, a 60 to 70% reduction in vertebral fracture risk, was observed as early as the first year and then persisted over the interval of the 3-year study. The cumulative incidence of hip fracture in both the Horizon and Freedom trials are shown here, and again, within months of beginning therapy, evidence of treatment benefit, protection from fracture, is observed with both drugs. The other point to emphasize is that in all of the studies that we have performed, there is evidence that the drugs continue to work as long as they're given. There is no example of patients developing resistance to either bisphosphonates or to denosumab therapy. We have several studies in which patients have been followed for out to 10 years. The first of those was the extension of the phase 3 alendronate study. Here, shown on the left, is the annual measurement of urinary N-telepeptide, a marker of bone resorption, an index of the effect of alendronate on controlling bone remodeling. Within months of beginning therapy, there's a prompt reduction in this index of bone resorption, and that value stays constant over 10 years of therapy. Shown on the right is the change in hip bone mineral density values in response to therapy. A marked increase in the first year of therapy. Gradually, the values plateau after some 4 to 5 years of treatment, but there is no evidence that bone density begins to be lost with long-term therapy. The longest data we have looking at fracture risk with therapy comes from the extension of the residronate studies many years ago. Over 5 years, patients received either placebo or residronate. What is plotted is the annualized incidence of vertebral fracture during the first 3 years of the pivotal fracture trial. Then in the middle columns, the years 4 and 5, where patients remained either on placebo or residronate, demonstrating that, as expected, the incidence of fracture increased in the patients who were on placebo, but didn't increase significantly in patients who continued on residronate. Then during years 6 and 7, everyone received open-label residronate therapy, and importantly, during those 2 years, years 6 and 7, the annual incidence of vertebral fracture was certainly no higher than it had been during the first several years of therapy. Again, speaking to the point that fracture risk reduction is persistent as long as therapy is given. Similar information comes from the extension of the intravenous zoledronic acid studies. After 3 years of therapy, patients were randomly assigned to either continue therapy or to stop. In the patients who continued receiving annual infusions of zoledronic acid, the incidence of vertebral fracture was no different during the second 3-year interval compared to the first 3-year interval. And with the extension of the denosumab freedom trial, hip bone density values continued to increase over the full 10 years of therapy, with a gain from baseline of almost 10%, 1 t-score unit of increase in bone density over time. And the likelihood of experiencing a non-vertebral fracture in patients on long-term therapy certainly was no greater and may even have been lower in patients on long-term therapy than it was during the first 3 years of exposure. So with all of our anti-remodeling drugs, bisphosphonates and denosumab, there is evidence of persistence of fracture protection with long-term therapy, with no evidence that the drugs lose their effectiveness with long-term exposure. And then lastly, upon stopping therapy, the treatment effects disappear. This is true even for bisphosphonates, where the pharmacology at least suggests that there may be a longer or slower off effect than with other drugs. When treatment of alendronate is stopped after 5 years, there is a gradual reduction in hip bone density, shown in the right-hand panel in the dotted blue lines. The values return toward but not to baseline during 5 years off therapy. In studies we did in younger postmenopausal women who received alendronate for 2 or 4 years and then stopped, as soon as therapy was discontinued, bone density began to decrease and gradually over time returned toward baseline. This off effect is slower than is seen when drugs like estrogen or other non-bisphosphonate drugs are stopped, but there is a gradual loss of the effect of bisphosphonates on bone remodeling, on bone density, and on fracture risk. The cumulative incidence of painful spine fractures in patients in the extension of the alendronate study is shown here. After 5 years of alendronate therapy, patients were randomly assigned to either discontinue therapy, their data is shown in the white curve, or to continue alendronate for another 5 years. During that 5-year follow-up, patients who discontinued therapy were twice as likely to experience a spine fracture as were patients who continued on therapy. Similarly, in patients with osteoporosis, the likelihood of having a non-spine fracture was twice as high as in the women who stopped therapy compared to women who continued on therapy. Similar results were seen in the extension of the zoledronic acid study. In women who continued on therapy during years 4 to 6, protection from vertebral fracture was evident. For women who stopped after 3 years, they were twice as likely to experience a spine fracture as were patients who continued on therapy. If we go back and look at the alendronate clinical fracture data, it appears that during the first couple of years, there's very little difference between the women who stopped and the women who continued, and this piece of information provides some of the rationale and justification, perhaps, for the so-called bisphosphonate drug holiday that we'll come back and revisit in a moment. The efficacy side, I think, is very clear. The drugs are very effective in reducing fracture risk. They work quickly. They work as long as treatment is given, and the treatment effect gradually disappears when treatment is stopped. The other side of the equation, of course, is the safety benefits. There are a variety of real or possible side effects that have been noted and discussed with regard to long-term bisphosphonate therapy. Some of those, like hypocalcemia, upper GI intolerance with oral drugs, flu-like acute phase reaction symptoms with IV therapy, all happen within the first few months of therapy, and there's no evidence of an increased risk of those complications with longer duration of therapy. The only complication that appears to be related to the duration of therapy is the occurrence of so-called atypical fractures of the femur, fractures of the femoral shaft that have unusual radiographic features that can occur in patients who have never seen bisphosphonates, but appear to increase in frequency with longer duration of therapy. The best data to support the relationship between a risk of femoral shaft fractures with atypical features and duration of bisphosphonates came from the Southern California Kaiser review of their entire population of patients receiving bisphosphonates. After 2 years of alendronate therapy, the likelihood of having an atypical fracture of the femur was 2 per 100,000 patient years, probably about the background rate. After 5 years of therapy, that risk had increased by tenfold, up to 20 per 100,000 patients. And after 10 years of therapy, the risk was approximately 1 in 1,000 patients. Importantly, in this study and in other studies from large databases in Europe, it appears that upon stopping bisphosphonate therapy, the risk of atypical fracture is quite quickly reduced. In the study in Sweden, a 70% reduction in the risk of atypical fracture was observed during the first year off therapy. We'll come back to that point in a moment as well. With the recognition in 2007 that these fractures with atypical features were a complication of bisphosphonate therapy, we have begun to understand a little bit about the epidemiology, at least. The risk factors for these fractures seems to occur more commonly in women than in men, and Asian women, older Asian women, are particularly susceptible, it seems, to these fractures. Of the 80 or so atypical fractures that I'm aware of in Portland, almost half have occurred in Asian women, which of course far, far exceeds the proportion of Asian women in the Portland geographic area. Hypophosphatasia is an uncommon problem where patients have a deficiency in alkaline phosphatase. We almost never look at alkaline phosphatase levels to wonder about what causes low values, but it turns out that Heterozygotes for hypophosphatasia occur in about 1 in 10,000 patients. And patients with hypophosphatasia have atypical femoral fractures without any help from bisphosphonates. Many patients that I've seen with atypical femoral fractures had low alkaline phosphatase levels and probably had or possibly had a defect in alk phos synthesis before they ever began bisphosphonate therapy. It's been questioned whether vitamin D deficiency, very common, is a possible risk factor for atypical fracture. The use of bisphosphonates in patients who are receiving glucocorticoids or proton pump inhibitors also may be an additional risk factor. We've recognized some clinical features about these fractures. Most patients have new pain in their thigh or groin months or at least weeks before their fracture appears. This gives us the opportunity to query patients about those symptoms and to interact even before the complete fractures occur. Periosteal stress reactions, evidence of the early stages of these fractures, may be evident on DEXA scans. We first observed this in a patient in 2010 who had been on alendronate for 10 years. We saw her in our bone density laboratory in 2000. She came back 10 years later, had been on alendronate that entire time. The technologist noted the defect in the lateral aspect of her femur on DEXA scan. That led to an x-ray demonstrating a stress fracture in that region. We discontinued the alendronate, treated her with teriparatide. The stress fracture healed. And since 2010, we've seen perhaps 20 patients who we have identified this periosteal stress reaction on DEXA scans in patients with no symptoms related to that lesion, even after we go back and question them, having identified the lesion. That, I believe, allows us to employ strategies to further minimize the likelihood of patients on long-term therapy experiencing this rare side effect by avoiding bisphosphonate therapy in patients with hypophosphatemia and in patients with vitamin D deficiency. We can, I think, minimize the risk. And then by counseling patients on long-term therapy to report new thigh pain and to alter the DEXA scanning protocol so the entire femur is examined looking for the periosteal stress reaction, gives us the opportunity, again, to identify incomplete femoral stress fractures and gives us a chance to intervene to prevent the development of the complete fracture. A variety of papers in recent months have attempted to quantify the benefit-risk ratio of long-term therapy. In a very thoughtful review in the New England Journal earlier this year, colleagues looked at the results of clinical trial data where we have placebo-controlled information over 3 years and made calculations of the number of fractures prevented with therapy for 3 years and the hypothetical or theoretical risk of atypical femoral fracture. And no matter what numbers you use for the risk of atypical fracture, the benefit in terms of fractures prevented far, far outweighed the likelihood of experiencing an atypical fracture within the 3 years of the pivotal trial placebo-controlled data. That's not very helpful because, again, we're not worried so much about what happens during the first 3 years. We're interested in what happens after 5 years of therapy. Our American Society for Bone and Mineral Research earlier this year published a paper with guidelines for the long-term management of patients on bisphosphonates, and in that paper attempted to put the frequency of atypical femoral fracture in context of the number of fractures prevented with therapy. And they looked at therapy for up to 10 years and again demonstrated that if the right patients are treated, that is, patients with osteoporosis at high risk for fracture, the likelihood or the number of fractures prevented with therapy, even out to 10 years, far, far exceeds the risk of having an atypical femoral fracture. I've attempted to put that same information into a different visual format. If one takes women who fit the average patient type in the Horizon zoledronic acid trial, 73-year-old women with femoral neck T-score values of minus 2.7, two-thirds of which had vertebral fractures, so patients at high risk for fracture, and treats them for 10 years, one can demonstrate that after 10 years of therapy, 23% of patients will have had a vertebral fracture prevented, 3.3% will have had a hip fracture prevented, while 0.1% would experience an atypical fracture. Again, highlighting the favorable benefit-risk ratio out to at least 10 years of therapy. And of course, we can optimize or magnify the benefit-risk ratio by choosing the right patients to treat. Patients at low risk of fracture are at risk for the complication, but receive very little benefit in terms of fracture protection if their fracture risk is very low. Whereas the absolute risk reduction is amplified when patients at high risk for fracture are chosen. We've got great tools to do that. The combination of bone density and clinical risk fractures that are incorporated into the FRAX tool and the guidelines for treatment helps us identify patients at high risk of fracture who are the ones who would benefit most from therapy. The combination of information we've talked about, the fact that stopping treatment after several years results perhaps in a reduction in the risk of atypical fracture without sacrificing the protection from fragility fractures during the first 2 years of therapy, provides the rationale and justification for the so-called drug holiday. Therefore, stopping bisphosphonate therapy after 3 to 5 years for an interval of 1 to 2 years may be justified in patients at low or modest risk of fracture. This was a statement made by the FDA in an editorial in the New England Journal in 2012. Again, earlier this year, our professional society task force published a paper that provided guidelines that helped codify and describe in more detail a strategy by which this drug holiday could be considered. So after patients have been on bisphosphonate therapy for 3 to 5 years, a reassessment of the need for continued therapy is made. For those patients who have had a hip, spine, or multiple other osteoporotic fracture, those patients are deemed to be at high enough risk that a drug holiday would not be considered. In the absence of that fracture history, then bone density testing at the time of reassessment is what guides the treatment decision. For patients who still have osteoporosis on the basis of hip bone mineral density, those patients, again, from the clinical trial evidence, are benefited by continuing therapy rather than stopping. So, for patients whose bone density remains in the osteoporosis range, or who by FRAX estimates of risk remain at high fracture risk, it's recommended that treatment be continued at least out to 10 years. Whereas patients deemed to be at modest risk of fracture, a drug holiday can be considered. It's important to note that the verb used to describe the drug holiday or to tell us what to do about a drug holiday was to consider a drug holiday, not to do a drug holiday. A drug holiday is an opportunity. It's not a necessity. The opportunity exists, again, because of the unique pharmacology of bisphosphonates, where there is the persistent protection from fracture for perhaps a year or two after stopping therapy, and the possibility that stopping therapy might protect patients from the one complication of long-term therapy. So after 3 to 5 years of therapy, consider a drug holiday in patients at modest risk, but for patients who remain at high risk, to continue therapy for at least 10 years. And actually, since this paper was published earlier this year, we have even more evidence that continuing to treat patients even beyond 10 years is appropriate. It's very important to note that while the discussion about drug holiday has been in our and general medicine literature for the last several years, there is to date no evidence that a drug holiday results in a reduction in the likelihood of complications of therapy. If one recommends a drug holiday, then another question is posed. When and how do we decide when a holiday is over? Monitoring bone density turns out to not be helpful in making that decision. Clearly, if there's a loss of bone density in patients who discontinue therapy, that makes it easy to know to restart therapy. But for most patients, bone density values change very little in the first 2 years of therapy. We can measure biochemical tests of bone remodeling, and in theory, this should be a strategy that would allow us to determine when the treatment effect of bisphosphonates is gradually waning. But the clinical evidence that we have to support the use of markers is, number one, very limited, and what evidence is there suggests that that strategy is not helpful. So in lieu of having a set of tests by which we can make this decision, in our clinic, we've sort of made up an empiric, hopefully practical strategy. The appropriate duration of a holiday after discontinuing risedronate should be no longer than 1 year. 2 years is probably appropriate for alendronate, and for zoledronic acid, perhaps as long as 3 years because of the longer half-life of zoledronic acid. At those time points, I then ask myself this question. If the patient came to me today and had never been treated, would I initiate therapy? If the answer is yes, then we look at the menu of treatment options, including bisphosphonates, and suggest that treatment be restarted. If the answer is no, then we'll postpone the decision about treatment for another interval of 2 to 3 years, at which we'll re-ask that question. I have no evidence that that is the right way to do it, but in the absence of knowledge about how we would use specific testing, this seems to be, in my mind, a reasonable and justified approach. Then let me, in closing, talk about non-bisphosphonate therapy and make the strong point that the concept of a drug holiday is only appropriate for bisphosphonates and has no justification when we think about other drugs. When non-bisphosphonate drugs are discontinued, the skeletal benefits disappear very quickly. We've known that for a long time with estrogen, with raloxifene, with teriparatide, and with denosumab therapy. When estrogen therapy is discontinued after 2 years, the data shown in the red line, the effect on bone density quickly goes away, and all of the bone density gained is lost within a year or so of stopping therapy. We looked at this in women who received estrogen for 4 years and had an increase in spine density of 6%. Therapy was stopped. The entire 6% gain in bone density was lost during that first year. Importantly, the markers of bone resorption very rapidly returned to normal, as you'd expect when estrogen is stopped, and for the first year of therapy, markers of bone resorption were higher than in patients who had received placebo. This led to concern because we know that rapid bone loss and high indices of bone remodeling are associated with increased risk of fracture. And there's been concern that upon stopping drugs like estrogen, that there might be a rebound in the risk of fracture where patients are at higher fracture risk upon stopping therapy than they would have been had therapy never been given. That's been looked at in the Women's Health Initiative. After several years of therapy, patients, the study was over. The women who had received either estrogen or placebo continued to be followed for an interval of 2 years. Like was seen in a number of observational studies, the risk of hip fracture in the women who had previously received estrogen quickly increased. but it increased up to the level that was observed in the placebo-treated patients. So there was a very rapid loss of the fracture protection effect of estrogen, but no evidence of a rebound or an excess fracture risk during the first year or two after stopping therapy. That was also seen when other fractures, spine fractures and non-vertebral fractures, were looked at as well. So fracture protection upon stopping estrogen is rapidly lost, but there's no excess fracture risk in the years immediately stopping therapy. Very similar information and concerns exist with denosumab therapy. After 2 years of treatment, increases in spine and hip bone density are impressive. Upon stopping therapy, all of the gain that had been made is lost within the first year of treatment. Indices of bone remodeling shown in the lower panels rapidly return to and above baseline and remain above baseline for an interval of about 2 years before settling back to pre-treatment levels. Earlier this year, 3 reports of 5 patients who had received denosumab for 2.5 to 3 years and who had impressive gains in bone density and then who stopped therapy were reported. Each of those patients developed multiple and or severe vertebral fractures within a few months after stopping treatment. Again, fueling the concern that there is a rebound in fracture risk upon stopping therapy. The details of those 5 patients are listed here. 4 of the 5 had quite severe osteoporosis at the time therapy was begun. The 5th patient, patient number 5, had begun aromatase inhibitor therapy for breast cancer, had experienced significant bone loss, but did not yet have osteoporosis, was then begun on therapy for 2.5 years. After therapy was stopped, within several months of stopping therapy, multiple vertebral fractures, as shown in the next to last column, occurred. Since then, other information has been provided. I had a meeting in Europe in the spring. It was reported from a group in Geneva that patients who had previously taken bisphosphonates before they received denosumab did not have the rapid bone loss that was seen in the studies that we had done in treatment-naive patients. Our national scientific meeting happens next week in Atlanta. Several abstracts will be presented that appear to confirm the rapid loss of fracture protection when denosumab therapy is discontinued. And we've had the opportunity of looking at fracture rates in patients in the long-term denosumab freedom trial who were either on placebo or on denosumab and then who stopped somewhere along the study. And we compared fracture rates in the first 2 years after stopping therapy. And as we observed in the estrogen studies, we see a very rapid loss of the fracture protection when denosumab is stopped, but no rebound or excess fracture risk during that interval of time. We also know that if patients get to a point where denosumab therapy might be discontinued, that switching to a bisphosphonate will protect them from bone loss. In a study we published several years ago, patients were randomly assigned to receive either alendronate or denosumab for a year. At the end of that year, they were switched to the alternate therapy, and shown in the yellow turning to green line, the women who took denosumab for a year, followed by alendronate, had preservation of their bone density without the loss that would have been expected. There are very, very few reasons to consider stopping denosumab therapy. There are no long-term side effects that we're aware of, or no side effects that increase in frequency with long-term exposure. There are patients who, because of the progressive increase in bone density that's seen over 10 years, ultimately get to a point where we think that there's little benefit for continuing therapy. If and when patients achieve that target of therapy, then it might be appropriate to discontinue denosumab and to intervene with bisphosphonate therapy at least for a short time to protect them from the loss of bone mass that would happen upon stopping therapy. I would recommend that at that point, 1 dose of zoledronic acid be administered. We know that zoledronic acid controls bone remodeling for at least 2 or 3 years after a single dose. And then after 2 to 3 years, reevaluate the patient and make further decisions down the road. So let me then outline a long-term treatment plan. For patients who receive raloxifene, raloxifene has a role, I believe, in treating younger postmenopausal women with osteoporosis who are at high risk for spine fracture, but who are not yet at high risk for hip fracture. There's no evidence that raloxifene protects women from hip fracture. But for younger postmenopausal women at high risk for spine fracture, particularly if they have concern about breast cancer risk, raloxifene is a very attractive drug. As the women grow older and hip fracture becomes a bigger clinical concern, then switching to either bisphosphonates or to denosumab because of the known protection from hip fracture is appropriate. For patients who have taken teriparatide, again, therapy for 18 to 24 months is generally recommended. There's very strong evidence that following teriparatide therapy with either denosumab or with bisphosphonates is appropriate. For bisphosphonate therapy, after 3 to 5 years, then to categorize patients into one of perhaps 3 categories. For women who are at low risk, consider a drug holiday and then reevaluate after a couple of years to decide when and if to restart therapy. For patients at higher risk, one could consider simply continuing therapy because of the known persistent effect of bisphosphonate on fracture risk reduction. For patients who remain at quite high risk despite 3 to 5 years of bisphosphonate therapy, I would recommend that we consider switching them to denosumab. We have evidence from several studies that switching from bisphosphonate to denosumab results in progressive increases in bone density which don't occur with persistent long-term bisphosphonate therapy. So if we're going to elevate patients from a very high-risk category to a lower risk category, using drugs in sequence would be the way to do that. And then denosumab therapy, again, as I've mentioned, there's rarely a reason to discontinue therapy, but if a reason occurs, then to consolidate the gains made with denosumab with a single dose of zoledronic acid would be appropriate in my view. So to summarize, after 3 to 5 years of bisphosphonate therapy, we're confronted with a decision to either recommend a drug holiday, which I think pertains to only a small proportion of the patients that we appropriately treat, to continue bisphosphonates for the majority of patients, and for patients who remain at very high risk, to switch to denosumab. In patients with osteoporosis, our current treatments can effectively, quickly, and substantially reduce the likelihood of fracture. There is an unreasonable concern about very rare side effects of long-term therapy that precludes appropriate use, in my mind, of these drugs. And while our drugs do have the potential for complication, the benefit-risk ratio, even with long-term therapy, remains extremely favorable. And until or unless we develop a cure for osteoporosis, long-term therapy of osteoporosis is needed. And as always, and as we've practiced in our clinic, there is no magic single formula for treating patients with osteoporosis. We don't treat osteoporosis, we treat patients with osteoporosis, and that means that therapy has to be individualized for each of our patients. Let me comment and remember my wife Betsy, who shared the development of our clinic with me. She passed away a year ago this week, and she's the one who actually helped me understand and appreciate that treating patients was what we as physicians do rather than treating diseases. Thank you for letting me share these thoughts with you. Questions or comments? Yes. Yes.
Thank you very much. That was a great lecture. I know a couple things on the slides that show the benefits of bisphosphonates from the longitudinal studies. It looks like the baseline bone fracture, I believe it's bone fracture, rates were quite different. And could you talk a little bit about the differences in population? And
Sure.
another question is, like the other studies, were there comparisons of the risk for fracture for the people that stopped biphosphonates to the placebo? Were there any placebo patients to compare to? And were there comparisons looking for that bump again that might be occurring or might not?
Great questions and very astute looking. So both issues have to do with the design of clinical trials. In the early days, in the 90s, when we first made the alendronate and risedronate studies, we had no effective treatments for osteoporosis, and there was little concern about having patients be in placebo-controlled trials. Once we demonstrated, after 3 years, that alendronate so substantially reduced the risk of fracture, then it was deemed unethical to have patients remain on long-term placebo therapy. So at the end of the pivotal trial interval of treatment, 3 to 5 years, the extensions of all of the studies, there is no longer a placebo group against which to compare. And of course, over time, there's a progressive dropout in patients. Perhaps the highest risk patients drop out with time. And so interpreting the long-term fracture data becomes problematic. For the alendronate and zoledronic acid trials, when therapy stopped, the control group is the patients who continue on therapy. And then we can attempt to compare back to the placebo rate during the earlier years, but your point's well taken. The differences in baseline fracture incidence across the history of osteoporosis studies has been a progressive decrease, again, reflecting the ethics of trials. So in the old days, we intentionally enrolled patients with a history of vertebral fracture, putting them at very high risk for spine fracture. Now that's not possible and not ethical. So the sample size of studies has gone from about 2,000 in the alendronate studies up to 16,000 in the most recent study, whereas the incidence of fracture in the untreated patients has progressively fallen. So each individual patient is at lowish risk, but it takes a bigger sample size to do that study.
Can you tell us the cost of the various agents you've mentioned today?
Sure. So alendronate costs $100 a year. Denosumab cost about $1,000 a year. Those are the two drugs that we most commonly use.
Looking at that low-risk group that you've treated for 3 to 5 years, would that be defined by a bone density that gets above the osteoporosis threshold? And also the high-risk group, would that be somebody who has not improved their bone density or maintained at a very low level?
Yeah. So in the absence of fracture data, bone density, I think, is the best determinant of whether a patient is or isn't a candidate for a drug holiday. And in the limited clinical trial information we have, if a patient's hip bone density has risen to a value above minus 2.5, especially if it's above minus 2, there is they are at low risk for fracture in the next couple of years. For patients whose hip bone density remains below minus 2.5, whether or not they had a big response to therapy, or even if they did have a big response to therapy, if their value is still in the osteoporosis range, they are, we think, at high enough risk of fracture to warrant continued therapy. Okay.
These studies and
Sure.
at what age and how often?
All right, so the recommendations for who should have a bone density test are based upon identifying patients at risk for low bone density. So the risk factors are being older, having had a fracture, and being thin, plus lots of other diseases. So it's recommended that women over the age 65 and older, men 70 and older, have a bone density test to assess fracture risk. For patients who experience, after menopause in women, after age 50 in men, a fragility fracture, a wrist fracture, a hip fracture, humerus fracture, bone density to categorize their risk as appropriate. And then for women who are thin at the time of menopause, in the lowest quartile of weight, that's a weight of 127 pounds or lower, those women predictably have lower bone density than heavier women, and so those are the agreed upon indications for therapy. How often to test depends upon what the initial answer is. If a patient has bone density that's very far away from your treatment threshold, then and isn't in a situation of rapid bone loss, then repeating the tests after 5 or 10 years is appropriate. If someone is nearer your treatment threshold, then a shorter interval, 2 or 3 years, would be appropriate. And then after therapy started, generally, I think assessing bone density 2 years after treatment is started, and then again at 5 years is an appropriate strategy.
We tell people, women, to do weight-bearing exercise. What actually is that consist of? What's the
Comment out weight-bearing exercise. Let me not define that, because there is no evidence in adults that weight-bearing exercise has any benefit on bone density or on fracture risk. Weight-bearing exercise is great for kids who are growing, but for those of us who are not growing, there is no evidence that weight-bearing exercise has any benefit to the skeleton. It has great benefit, of course, to muscle function, but that's a different issue.
Can you comment? You showed the very low rates of treatment even after hip fracture, and I feel like the hospital is oftentimes a setting where we can capture those patients and start them on a bisphosphonate, yet maybe they've been tested and their vitamin D level is a little low, so we say, well, let's put the bisphosphonate off until we've repleted their vitamin D, and then it gets lost. Can you comment, is it a reasonable strategy to just start repleting vitamin D and start the bisphosphonate at the same time, so we're not missing these patients?
No. Great question, and that the idea of having a fracture liaison service so that the patients who present to the ER or to the hospital with a fracture are followed up in a systematic way, it has been demonstrated worldwide now to be an incredibly clinically effective and cost-effective strategy that Providence should do. For hip fractures specifically, if one is to begin alendronate or an oral bisphosphonate, then beginning vitamin D supplementation and alendronate simultaneously is really not a problem. And to administer a single dose of 50 to 100,000 units of vitamin D, one loading dose, assuming the patient isn't hypercalcemic, and then to have them be on maintenance therapy will preclude any problem. Giving patients IV zoledronic acid in the hospital may be problematic, not because of D deficiency, but because of the high remodeling at the site of the fracture, where all the drug goes to the fracture site and not to the rest of the skeleton where you want it to go. So if IV therapy is chosen, then to wait a month or 6 weeks after the fracture before the dose is given would be appropriate. And I would also, again, be more careful about beginning denosumab, because it's such a potent inhibitor of bone resorption that hypocalcemia is more important and probably would allow at least a couple of weeks to happen before therapy started.
There's been some pushbacks from orthopedic surgeons starting bisphosphonate specifically after doing a surgery to repair a hip fracture. Do you have any comments about?
Yes, I think that, so the point is that orthopedists are concerned about the use of bisphosphonates immediately after a fracture. That theoretically, there was worry that impaired fracture healing might be a complication of bisphosphonate therapy, but both in lots of animal studies and in all of the clinical data we've done, there's no hint that that's true. It takes a little bit longer for the callus to mineralize as a fracture is healed, but the ultimate strength of that healed fracture is better in bisphosphonate-treated animals than it is in not treated animals. So there's no harm to either the fracture healing nor to the seating of an implant after hip replacement, for example. In fact, bisphosphonates, by inhibiting resorption, minimize the loosening of prostheses and minimizes the failure of implants.
You mentioned vitamin A deficiency as a risk factor.
Vitamin D.
Vitamin D, sorry. Yes, thank you. Vitamin D as a risk factor for atypical fractures. Can you talk a little bit about that in particular, and how do you go about what's the sequencing and treating that, but also in general, in terms of surveillance of the patient who's on these medicines, do you look for vitamin D, and how often do you look for it? So,
of course, about vitamin D, we've had grand rounds about vitamin D here for the last many, many years. So very briefly, free-ranging adults in Oregon and the rest of the world live with a serum 25-hydroxy-D level of 20 nanograms per mil, which is the definition, or lower than that, is the definition of deficiency. So half of us are deficient no matter what we do. I personally think, since vitamin D measurements are so expensive, it costs way more to measure vitamin D, $180, than it does to treat somebody for a year or to even to measure a bone density, that I think that screening really isn't important. And in the absence of hypercalcemia, there are no contraindications to vitamin D supplements. So I propose that, particularly for patients with osteoporosis on therapy, that we simply ensure that their daily intake of vitamin D be somewhere in the range of 1,000 to 2,000 units. And unless they have, unless you have concerns about GI absorption, celiac disease, gastrectomy, or unless they're on drugs like cimetidine or dilantin that muck up vitamin D metabolism, or unless they have severe renal insufficiency that alters vitamin D metabolism, I think there's no benefit or need for continuous monitoring of vitamin D in patients on long-term supplements. One more question. Oh, sorry. Okay.
Would you comment on if you would treat men with osteoporosis or people with or on long-term glucocorticoids or phenytoin
Sure.
differently?
So men with osteoporosis ought to be treated just like women. The data documenting fracture risk reduction is not as robust in men because it hasn't been necessary for registration. But what data we have suggests that men respond the same way to all of these drugs as do women, and the indications, the criteria, the strategy, I think, is the same. For glucocorticoid therapy, it's different. The pathogenesis is very different. Teriparatide has a much more important role in patients on long-term glucocorticoid therapy, and studies published 10 years ago now in the New England Journal documented dramatically more effective risk reduction of vertebral fracture with teriparatide than with alendronate. So bisphosphonates reduce vertebral fracture risk by 70% in patients on steroids. Compared to that, teriparatide reduced the risk by another 90%. So for patients on long-term therapy, that is more than a year or two, intermittent therapy with teriparatide, I think, has an important role. Okay. So I'll be happy to meet you up here. Thank you very much.